welcome you to this CSO virtual webinar. I am delighted to and very proud to be invited by the CSO to moderate this session and to be a speaker with such eminent speakers. We will start with Dr. Shady Awwad. Dr. Shady Awwad, please start with your talk.
Thank you, Mazen. Thanks a lot. So again, special thanks to the CSO team for inviting me and for organizing such a nice activity. So I'm going to start by sharing my screen. Okay. All right. You could see my screen, right?
Yes, we can, Shady. Yes, we can.
Right.
Yeah,
so I'm going to start. Excellent. So the first talk of this session will be about the importance of OCT in corneal tomography. And is really OCT is better. Now, what I'm talking here is not anterior segment OCT. I'm talking using OCT in your daily workhorse, routine, out of the mill, corneal tomography. Do you really need OCT if you're just doing tomography before, after LASIK, checking quickly keratoconus, not your very hardcore cornea specialists who want really all the fine details of the anterior segment of the cornea? Is OCT is really good, and do we think, or do I really think that it is better than Scheimpflug? Well, I really think there is 1, 2, 3, 4, and even 5 reasons why OCT performs better and actually does things that Scheimpflug cannot do in your routine, out-of-the-mill tomography exams. So let's discover these. First, we always think, you know, beauty is always skin deep, right? And I think whatever is deeper than the surface is actually where the OCT does the best, and it's actually better than Scheimpflug. So here I'm talking about things that OCT does better than Scheimpflug. So the same thing, both can do the same job, but OCT does it much, much better and more beautiful. So let's first start by pachymetry. Well, of course, pachymetry is uses the anterior and the posterior float, and the posterior float is really critical because if you cannot measure it very well, you don't get accurate pachymetry. For instance, let's take a look at that patient post cross-linking, happened to have also corneal ring segments, and you can tell that that patient has some haze post cross-linking. Now, what the MS39 shows with OCT-based pachymetry is 368 as the thinnest point. Let's see what the Scheimpflug would give us. It could give us 308, a difference of 60 microns. And of course, this is very common post, not just cross-linking, but any patients having a lot of haze. And the more the haze, the more this difference. This scatter has been shown before. We have showed it in AJO by using a prospective study comparing ultrasound, OCT, and Scheimpflug. And we showed that OCT suffers much less than Scheimpflug, whereas, of course, ultrasound doesn't suffer at all. But the problem with ultrasound is not holistic over every single point of the cornea. So OCT suffers very minimally, while Scheimpflug suffers a lot. And that's very important if we're looking at pachymetry. Now, how about better posterior float? Let's take a look at that patient who had a small disc scar anteriorly in the cornea. Let's take a look at what Scheimpflug would show from the posterior best fit sphere, and you could see like a coin elevation. If that coin elevation was somewhere even more centrally or inferiorly, we would think of possible keratoconus. But we need to look always at the exam before looking and diagnosing a topography or a tomography. We need to look at the same time at the slit lamp exam and make sure that there's nothing wrong. If you look at the OCT best fit sphere of the MS39, we see that it's completely clear. There's no artifact, there's no elevation, so this is pure artifact. Interestingly, Theo Seiler has spoken about this before, not just exactly this example, but spoken about how OCT was less liable to scatter than Scheimpflug. Now, how about the posterior curvature? Now, of course, if you're looking at IOL calculations, especially after refractive surgery, or even worse, after RK, we have to look at total corneal power. And if we want to compute total corneal power, if we're using Scheimpflug, especially in irregular cornea and hazy cornea, like in this patient, post-RK, and we see often they come accompanied with haze, the posterior curvature is not accurate. Again, it suffers from the scatter and from the haze, and that's why it's important to look at OCT technology to compute the total corneal power. How about now posterior curvature? So not just float, now curvature. Take a look at this patient. You could see the asymmetrical elevation temporally. And one would tend to think that this might be keratoconus. Now, this sometimes is due to a high angle alpha because the eye is kind of rotated and the best fits field suffers from that. This, I call a typical artifact. Now, very little devices measure angle alpha, and sometimes it's hard to organize the tomography based on this. But if you take a look at the posterior curvature, you could see that the posterior curvature is pretty symmetrical here. It's a nice symmetrical bow tie. And that's why it's nice again to take a look at the curvature, which does not suffer from artifact. So you could rely on OCT for much better representation of posterior curvature. Now, we've been looking all the time over the past few slides over everything that is deep, but it's nice sometimes to see that OCT now shines in something that is much more superficial all the way up, and that's the epithelium. So while sometimes we go search for the nitty-gritty details, especially in keratoconus and our post-refractive patients on the posterior float, we forget sometimes how deep of an impact the epithelium has on our overall tomography. So for instance, that patient, that's a pretty simple example of a patient 1 day off contact lenses. And again, that's very same patients 2 week off contact lenses. And you can see the major improvement in the epithelium and definitely in the anterior curvature as well. How about epithelial toricity? I'm going to give you an interesting example of a patient I operated on having high astigmatism. This is the right eye, and then up was the anterior instantaneous curvature, and the bottom was epithelial mapping. Now, let's take a look at the other eye. That's the other eye, much higher astigmatism, but still in oblique astigmatism. But take a look at the posterior, the epithelial mapping, and interestingly, we see a lot of epithelial toricity. Here, I'm using the scales that soon the CSO in their new software actually changed them. So here, what you see in red is actually a lot of thickness. And the epithelium is trying to camouflage some of that steepness along that oblique meridian. Interestingly, that has a lot of impact, whether we're going to do alcohol PRK or mechanical alcohol PRK or trans PRK or femtolasic. And that's important to take a look at the epithelium before sometimes deciding or embark in a special procedure where we're going to go. Damien Gatinel has talked a lot about the epithelium and the role in toricity and, of course, in total corneal power before and after epithelial removal. And this is one of the nice examples here. Now, how about incorporating the epithelium and the posterior curvature to accurately diagnose patients presenting for refractive surgery and find out if they're good candidates or not? Let's take a look at this hexa map. I like to call it hexa map because it has on the left-hand side the red-free Placido image. I want to see if the eyelids are covering a lot, if we have good exposure, if the Placido are broken, if the patient has high angle alpha or kappa, I can see the Placido that are deviated. On the bottom, you have the epithelium. In the middle, I have the instantaneous curvature. On the bottom, posterior curvature. Then you have the pachymetry, and here you have the BFS. I don't like to look at the anterior best fit sphere. I don't think it adds a lot to what I have here. So if you want to take a look here, you see that the anterior instantaneous curvature is pretty steep inferiorly and is asymmetrical. However, the posterior curvature is neat. It shows a very nice symmetrical bow tie. And I can rely on this because it's derived from OCT. And as you know, the posterior curvature as a negative cylinder is about 1/7 of the total corneal power as represented by the anterior curvature with the keratometric index. So the 1.5 diopter scale, 1 to 1.5 diopter scale of Kleist, the absolute scale, I converted to a 0.2 to 0.3 diopter scale. And because it's OCT, it's pretty accurate. I know Scheinfeld cannot derive a 0.3 diopter accuracy here, but OCT can. And more importantly, it's not associated with artifact. So I can look at it and see and say, well, these do not look, as if they go along. Probably the epithelium has an important role here. And again, looking at the epithelium, you can see that the epithelium is thick inferiorly and thin superiorly, which account for that. But the nice thing is that of just looking at those two, I can look at my posterior curvature and see that actually that's nice. Looking at the BFS might not be as easy in comparison because I can't compare really BFS to curvature. So here it's nice because I'm comparing apple to apple, not apple to oranges. Now, that's another example, maybe more extreme example, where this is the anterior instantaneous curvature, and that's the epithelial mapping. This patient is not a contact lens wearer, and you could be amazed, and the patient does not have dryness. But it's amazing how sometimes the epithelium remodels, maybe rubbing, maybe the way the patient sleep over his eye, maybe over the right eye or so, but that's interesting to compare, and that's again the posterior curvature. Apart from this artifact at the periphery, you could see that it's a nice circular, not much of an astigmatism in here, and it's more of a round structure as opposed to the anterior curvature. So again, curvature is interesting for me and is important, not just float or BFS. Now, how about following refractive surgery? We're used to look at the epithelium to diagnose keratoconus or to screen patients for laser vision correction. But how about to follow up your run of out-of-the-mill patients? This is a post-myopic patient, as you can tell from the instantaneous curvature with the flat center treatment. That's instantaneous. And again, looking at the OCT, not the HD. This is the regular OCT that you get when you do a routine tomography. So I don't have anything in mind, and I don't do regular high definition OCT right away to save time. But I can tell right away the depth of the flap centrally and periphery. I can tell the patient had previous refractive surgery, and he had LASIK as well. And by looking at the epithelium, I think that's even more important to follow your patients. So if you try to make it a point to do the OCT-driven tomography pre-op and post-op on all your patients, you get to understand where these patients lie, whether these patients are overcorrected, undercorrected, or whether they regressed or not. For instance, this is a myopic patient, and the patient has minus 3.5 diopter of sphere. And look at what happens post-transepithelial PRK 1 month after. You see there is an epithelium. Again, this is the older scale, soon it's going to change. But what you see here is actually thin epithelium in the center. The epithelium didn't have time yet to thicken. As we know in post-myopic patients, the epithelium should be thicker in the center, but it's not yet. And that explains why the patient usually typically have hyperopic shift for the first few months. Some patients more than the other. So if you can compare to the epithelium, you could reassure yourself that this overcorrection is from the epithelium yet, and it's not yet a true overcorrection. Some patients have a quick epithelial faster recovery, some patients have less. Sometimes for me, it's time for me to decrease the topical steroids, because topical steroid will make the epithelium a bit obtunded, a bit lazy, and everything looks fine, no haze. I cut down on the steroids and get the patient get that epithelium much quicker in recovery. That's again the same patient and about 3 months post-operatively, and as you see, the epithelium is getting thicker, but definitely it's still thinner in the very center than the periphery. So at 3 months, the patient is a little bit hyperopic. I'm not scared. I know that's gonna keep getting better. And again, I can tweak my treatment accordingly. Now, very interestingly, we know from Dan Reinstein that the epithelium remodeling is really not affected by just depth, but it's more affected by curvature. The more sudden the curvature, the faster and more dynamic the epithelium will try to heal to camouflage whatever you have. So in here, we have a dent from a previous melt, and as you see, the epithelium will almost remodel to completely seal off any refractive effect coming out from that melt. And that's very interesting. And this reminds me of Paulo Vinciguerra with his curvature gradients, which he talked about almost more than a decade ago. And he always voiced for large optical zone. So what happens with large optical zone is you have less curvature gradients, exactly opposite that example that Dan Reinstein showed us before, and then it will induce less epithelial remodeling. And that's very important to look at your patients with OCT technology, like if you have the MS-39, and that's why it's important to do it before and every visit after. So you have to do it so that you can compare. This is a patient, again, post-myopic treatment, 3 diopters of myopia, and you see the patient has 62 microns, much thicker in the center than at the periphery. The periphery at 52. Let's take a look at exactly the same patient, but hyperopic plus 3 diopter. And as you see here, you have 73, a whopping high elevation of epithelial thickness, and actually a thinning in the center, so that the gradient 73 to 44 is much more than the gradient of the myopia. Now, this is not the case. This is not always written in stone. I can see patients who have much less gradient and patients who are much more, but I've noticed that the larger the optical zone, the less the tendency to have this discrepancy. But because you have this discrepancy, that explains sometimes why you have this big scatter in spherical equivalence in post-hyperopic treatment as opposed to post-myopic treatment. And that's why it's very important always to enlarge the zone, but more importantly, to see if the patient truly regressed or not, to look at your epithelium and look over time and see if it's changing or not. If this regression is paralleling in a change in your epithelial gradient, as you can see here. So that's why I think if you're not looking at the epithelium, you're not doing refractive surgery. And that's not me, that's what Dan Einstein said. I think you might say it's biased, but the more I do my OCT, the more I do my tomography based on OCT and I make it a routine, the more I discover that this is so true. Now, again, if you're a refractive surgeon and a true refractive surgeon, you're not gonna let yourself just do DALK for keratoconic patients. You're gonna try everything before you get to DALK. So you're gonna be putting corneal ring segments, do cross-linking, do topography or corneal wavefront guided, and even phakic IOLs, and probably everything one African Costco 7 calls the quadruple procedure. I mean, you can do some, all, whatever, but you definitely have to treat keratoconus as a refractive discipline, more than just pure hardcore cornea. And again, if you look here, by just doing regular tomography, you can diagnose haze and you can follow up on haze, especially post-cross-linking. You can look at the demarcation line and see how deep the cross-linking was. And you could look at corneal ring segments and see how deep they are as well. So there are so many things that you do from your routine tomography, not just looking at anterior float, posterior float, or curvature. Like for this specific patient, for instance, do you think the patient came and told me, well, I've had cross-linking before, but I'm not sure. I think I had laser at the same time. And I was like, did the patient had PTK with cross-linking, or he had a topography guided PRK or corneal wavefront guided PRK with cross-linking? That's important to find out. He has a good demarcation line, as you can tell here, but how can you find out? Again, by tomography using OCT, you can. If you can take a quick look, there is one sign that is so pathognomonic, and you can tell that that patient didn't have any kind of PRK or PTK. Now, that sign would be the Bowman's layer, as you see here, the bilaminar layer of Bowman's membrane. And you can look and scan through, it's there. So that's the importance, again, of OCT here, not just looking at the anterior float or posterior float. I'm gonna put two quick cases to illustrate how we use the OCT. That's a case that presented to me not a long time ago, actually. And the patient had a trauma in her eye, and she had LASIK done about 15 years ago, somewhere in another country. I have no history about that. And as you see here, it was a rubber band, so the flap was torn. If you see my cursor here, this was where it's torn, and the flap was all lifted. I repositioned everything and told the patient there's a risk of epithelial ingrowth, and followed the patient for 5 days. Everything was fine. Gave her an appointment 7 days later. So about 11 days, the patient comes with this sudden picture. So central epi ingrowth, and as you see here, temporal from where the flap was dislodged. So I thought maybe central was from the incision up, maybe this from the flap. Wasn't sure. I looked at the slit scan by the slit lamp, and I'm like, okay, but these kind of look pretty superficial for me. And again, looking at her OCT tomography, as you're gonna see here, and looking at the anamorphic image. And I would all encourage you to look at the anamorphic image, because it's pretty simple and it's built in on your regular low definition OCT in your tomography without having to resort to a special OCT. And as you see here, this is the flap. The flap is the black line you see here. This is the interface, I'm sorry. And those are the epi ingrowth. If you see even peripherally, it's the same. Interestingly, this is an ingrowth that went through the stroma, but not the interface. How often is that? Not often at all. I've never seen that before. But actually, that actually helped me to take the right decision, because otherwise I would have lifted that flap to find nothing. And as you see here, again, on big zooming, you could see where the flap is. This is the line. It's clear all through, but even more at the periphery. I thought maybe the center was actually above the interface and the periphery was from the interface, and maybe it started deep and went and migrated, because I can see something like that. But what I saw here is actually no, everything was above the interface, as if it was in the flap. Of course, the periphery was kind of deep, the center was kind of shallow, which I can target with my PTK. So I decided to go ahead with PTK, put mitomycin. Hopefully mitomycin would kill those epi ingrowth at the periphery a little bit they would be now shallower than I did my PTK. And that's what I did actually. I'm not gonna put the video, have the video, but because I'm trying to decrease all the data here on Zoom, but I did a PTK, a trans-epithelial PTK, applied mitomycin C for 45 seconds. And then this is what the patient, this is the picture 1 month after, nothing, clear centrally and peripherally. This is central and this periphery, there's nothing, no epithelial growth, nothing. I did not relift the flap. And that's really great. I could not have done that without an OCT. And that helped me really make the right diagnosis. And I'm gonna last do one case discussion talking about one thing that is often missed, and this is the posterior aberration measurements. We think about tomography, but we don't, we forget sometimes that actually we can measure the posterior curvature and from it deduct the total corneal aberration and the posterior corneal aberration. Now, why is that important? Again, I'm gonna show this case, and that's going to be the last case. So this is a case post cross-linking with haze, as you see here. The patient is 20/40 plus. He has some aberrated eyes. The haze is there, but somehow it's coping with RGP. The patient is much better. What I saw when I'm sorry, this is the hexa map again, the epithelial map, the posterior, the instantaneous curvature, and the posterior curvature. And as you see, the patient suffers quite from coma. This is the aberration map, the total corneal aberration map from the MS-39. And if you look at dissect the anterior, posterior, and total, you could see that the anterior coma is 0.86 diopter at 100. However, the posterior coma is 0.41 at 285. So it's almost 180-degree opposite. And interestingly, that subtracts from the total, from the anterior, and the total is 0.43. Now, if we do regular topography guided or anterior corneal wavefront guided, that's what we're gonna treat, 0.86. But if we do that, that's gonna expose the 0.41 here, and then we're gonna end up with 0.41 exactly where we started. So that's crazy. I would not do that. And that's how you could locate it with the OCT-based tomography. Now we think if I have Scheinflug, I don't think so because the patient had haze, he's post-cross-linking. And guess what? Most of your patients coming to you are gonna have irregular corneas, haze, and your Scheinflug from the lower definition and higher susceptibility to scatter is not gonna be able to provide that. So if you look at I'm blessed to have also a pyramidal system aberrometer from CSO as well. It's the Pyramis is also called the Osiris. So I run it always, and I always take a look at the holistic picture of the eye. And what I saw here is actually the ocular higher order coma. The total coma was 0.46 on 92, was almost the same as my total corneal coma. So now, because I don't have the luck, we don't have yet the technology of total corneal customized treatment, I can do ocular. The patient luckily had big pupils, and I have a higher definition ocular aberrometer. So I treated ocular higher order aberration because that would end up treating only the total sum of the anterior and the posterior curvature. And sure enough, that's what I went ahead with ocular wavefront guided transepithelial PRK. And what I got is actually pre-op this topography, post-op this topography, instantaneous curvature. And one would say, yes, you still have some, a little bit of cone down there, some coma is in there, yes. But take a look at the aberration, which is more important than your anterior surface. And as you see here, the anterior higher order coma was 0.39 at 103, but the total higher order was almost 0. And again, the posterior didn't change. It was 0.44, exactly negating the anterior higher order aberrations. And that was really nice because what I learned from Bruce Allen and from many others, that actually the posterior compensate always from the anterior aberrations because they sit on a negative meniscus, notably coma. And if you try to treat total higher order aberration ocular, you will end up saving around between 30 and 44% less tissue because you don't have to deal only with the anterior and because the posterior negates some of the anterior. Now, again, this might not be feasible all the time based on the pupil or based on the type of aberrometer you have or the type of severity that the keratoconus has. But it's nice to keep in mind and keep ocular wavefront guided on the armamentarium together with topography guided. And again, this is to illustrate this anterior and this posterior curvature, and they both contribute due to coma diametrically opposite. And finally, ocular wavefront guided is on the armamentarium, but again, wouldn't be nice also to have total corneal wavefront guided treatment, and that is possible only with OCT because with Scheinflug, it's garbage in, garbage out. You have good acceptable measurement, but you cannot rely on it in very irregular eyes, the very eyes you need to treat. So finally, as a conclusion, We know that OCT does things better than Scheinfeld, and there are many things that OCT does that Scheinfeld does not. And that's why I think it is important in your routine, out-of-the-mill tomography evaluations, pre-op, post-op, and all levels. Thank you.
Thank you very much, Dr. Shady. Amazing as usual. Actually, you highlighted a lot of aspects regarding using the MS39, be it the OCT itself and the epithelial mapping. Now, we have a question from one of the audience. How thick was the PTK done at the first case? So he means, what was the depth of the PTK?
Yes, the epithelium was actually down to about 100 microns. So we went all the way to 100 microns. The flap was about 130. I remember about 105. So I went 105 to remove completely the central epi ingrowth. The peripheral ingrowth was deeper because the flap was deeper. It was about almost 150. But we're using mitomycin C. Interestingly, I could see the epithelium the first day. I could not see them 3 days out, completely disappeared. As you see also with the photo.
Sorry. Now, what about the refractive outcome? Because we know that the PTK may cause hyperopic shift. So what was the refractive outcome?
First, here, the patient, what we do is we do a very large optical zone. So for me, when you use very, very large, I use the Schwind MRS and I can use very large optical zone. I don't have much of that outcome. Two, we have transepithelial, which means we account for the epithelial thickness also peripherally because we treat more on the periphery. But more importantly, I do smoothing, and I learned that from Paulo Vinciguerra. So I do fluid masking and smoothing, and that's what I did actually here, and that smoothed out even more the irregularity in the center. So the patient had myopia anyway before because she was treated before, and that patient was myopic. So right now, it's been almost 2.5 months, so I can't judge exactly right now, but she's still myopic, so it didn't induce much of hyperopia now, but it will be probably too early to judge.
Okay, what do you mean by the very large optical zone? Up to what? 8 millimeter, for example?
So I use 9 millimeter optical zone.
9.
At least. Yeah, and the laser goes out from 9. It does a transition zone to 9.5. So I always use at least 9 millimeter. Yeah.
Okay, that's great.
With the Schwind, you can do that. Yeah.
Yeah. Any of the panelists would like to ask Dr. Shady before we move?
I have a question to Shady. What do you
Hi,
think?
Jorge.
Hello. In this case, probably I would have first thought about maybe just removing the flap directly, mechanically, and then you avoid any excimer ablation. What do you think? I know that this probably is not the topic of the presentation, but what do you think is probably the benefits or risks among both options, large PTK or
I don't know if you noticed, but all the epithelial ingrowth was in the flap. There was nothing under.
Yeah, that was the reason to remove.
And that's what I'm saying, because when I did it, I looked. That's what I was saying. Nice to look at the anamorphic, because the anamorphic are there even if you're doing a regular tomography, not even an HD OCT. So if your technicians are busy, they're not going to do an HD OCT on every single person. But you're looking at the anamorphic, it's interesting because you see that the flap is deeper than even the peripheral ones, because I thought maybe it's feeding. And then when I started doing all my HD, I could not get any single point where the epithelial ingrowth was deeper, so it was in the interface. And that's why if I'm gonna lift, I'm not gonna get anything. I'm gonna lift, I'm gonna delay everything and I put it back. And that's why it was clear for me. And I had actually, instead of getting the patient 2 trips to the laser room, I just did it once.
Yeah, well, I was meaning not lifting, just amputating the flap.
Now, why would you? I mean, if you have a nice, with PTK, you can do nice smoothing. Why would you, amputate and even get suffer more? I mean, I love PTK. I think, I learned a lot from a lot of colleagues, including Paulo Vinciguerra, and I use it a lot. And I think this is kind of customized treatment. It has much less implications on refraction. If you do smoothing, it will even smooth it out more.
Yeah, it was a very nice case. Thank you.
Okay, thank you, Dr. Shady. Now we will move to the second speaker, Dr. Juan ArbelaezMuscat from Oman. He will talk about keratoconus management and intracorneal ring treatment in the era of anterior segment OCT. Please, Juan.
Thank you, Mazen. Regarding the Jorge's question, I want to share a similar case that Shady presented, but this case was not epithelial ingrowth. This case was fibrosis. The patient had a PRK over the flap, and as you can see here, the reason why I decided to perform a flap amputation is because I saw clearly with the high definition section of the MS-39 how smooth was the residual bed, and this is what we got after the removal. It's a pretty homogeneous cornea with still good thickness, but it's very difficult to judge in cases and when you still have a doubt if this is epithelial ingrowth. Knowing your image was very clear, my image was completely different. It was fibrotic reticular haze, what you were able to see along the flap. But your image is impressive to see that all of this epithelium was not in the interface. I'm very surprised to see that.
Exactly.
Okay. Let me just play my presentation. I will talk a little bit about the keratoconus screening. I'm not seeing my camera. You guys can hear me and can see me?
Yeah, we can see you and we can hear you.
Okay, perfect. Okay.
But we cannot see the
So
presentation.
the first keratoconus.
Did you share the presentation?
Yes.
Yes. Isn't it share? Okay, let me just technical issue here.
Did you click on the share screen?
Yeah, but I was in the share screen of the case that I show you guys.
Yes. Now we can see the presentation.
Now we see you. Yeah, perfect.
Okay. Okay. So I will talk, as I was saying, about a little bit about the keratoconus screening software that we have available in the MS-39 and the applications of the software, the Phoenix on the MS-39 for the implantation and follow-up of patients with the intracorneal ring segment. So here was the initial keratoconus screening software that we have. This was published in the Ophthalmology in 2012 by Dr. Maria Arbeláez. And now we are working with Jorge, Aliò, and Francesco in strengthening the software of the MS-39 for the screening of keratoconus patients. Well, as we know, we already are, everybody's aware about the benefits of tangential maps over sagittal maps, but sometimes we wonder if the steepest point is the right location of the cone. For example, in this particular image, you can see in the anterior curvature and the posterior curvature that is located in two different places. So we might think that the location of the cone and the weakest area of the cornea is this point here in the tangential map. But now with the Gaussian curvature maps, Gaussian curvature maps are a little bit tricky to explain and understand. The sagittal and tangential curvature, as I was saying, is defined in meridional basis, and it ignores the orthogonal component of the curvature. And the Gaussian curvature does not present this type of approximation, and it's very useful to detect the location of the ectasia. It's axis independent. It will hide completely the astigmatism and shows the exact place of the ectasia. The best way to understand Gaussian maps, you have a normal piece of paper where it has zero curvature, but let's say you scroll this piece of paper and you make a cylinder, the curvature of this page is still zero, as you can see here in the image in the middle. But if you try to fit this paper in a spherical component to produce a positive curvature, you will see that you either have to fold or tear the piece of paper to be able to create this shape. So this is what is measured exactly by the Gaussian curvature maps. So here in the Gaussian curvature maps, you can see how nice is identifying here the posterior curvature and the exact location that is different than what was identified by the tangential posterior maps. So this is extremely useful to locate the exact place of the ectasia, the use of these maps. We also use elevation maps versus normality. And we have, with the MS-39, the possibility of evaluating the epithelial thickness, the total corneal thickness, and only the stromal thickness without the epithelium. Here is something that I want to highlight because people get confused when they see epithelial maps. Epithelial maps from some other devices, when they started showing the thinnest points as cold colors. So this area that looks a little bit darker, that is a colder color, it's with this scale is a thin area of epithelium. But if I change the scale, that is also possible with the MS-39, I will say that I can do that. This exact same map looks like this map that is more in correspondence with the maps that we see of elevations and thinning, like the stromal, corneal, and now here the epithelial map. And I wanted to highlight with this image also that you will not always see this characteristic image of, for example, this is a case of keratoconus suspect, where you see thinning in the center and a little bit of thickening around. Sometimes it's not, because this is not the location of the cone. In this particular case, the location of the cone was not in the center, was paracentral inferior. So this is the area where you will have the thinning, and the thickening will be around that area. This is, for example, another case is after the implantation of corneal ring segment. So we see that the epithelium gets thicker along the implantation of the ring, next to the ring, and then the thinning of the epithelium in the center in a keratoconic eye. With the next image, the same screen map is using an applanation image of the section of the OCT. So as Shady was saying, it's super helpful when you are evaluating an eye to be able to identify, for example, if this case was a keratoconus or maybe it was a post-LASIK ectasia. So in this image, you clearly see these two lines. This is the first refractive index that is shown from the Bowman's layer. So here you can see the Bowman's layer and then the flap that is this area. So you will know that this was not a keratoconus case. Maybe this case was a post-LASIK ectasia. And also you can notice the difference in a case down here where you can see that this case was already treated either with PTK or PRK because Bowman is not there, it's absent. And it's also very useful to see the changes of the epithelium after implanting, for example, intracorneal ring segments, and the definition allows us to clearly identify all the structures of the cornea, the epithelium, the Bowman's layer, and everything else. Okay. We also use the pattern deviation maps, and the pattern deviation maps show for each point the value of the difference from the average of the healthy population in terms of a standard deviation. So it's very useful to identify, because all the maps, normally the normal cornea will be thinner in the center and thicker in the periphery. But if we compare it with the standard deviations in the normal population, it will highlight the area where the cornea is exactly getting thinner. This is very interesting. The red on red map, or the red on red image, is the Placido disc image that highlights 7 points of the cornea. Each of these points are explained in this image if you guys want to take a screen capture. And it uses the Gaussian maps, then the anterior elevation versus the normality, the epithelial thinnest point, the stromal thinnest point, and the corneal thickness thinnest point, and put them all together. In a keratoconic eye, the notable points tend to be very close together and concentrate in a very small area. But in a normal eye, they are widespread along in a wider zone. The spreading zone is calculated as it's represented as a circle that is centered on the body center with the notable points radius. I think they are sending me here a chat, Mazen, from the speakers, or? Am I right on time, or?
Yeah, you are right on time. No problem.
Okay.
Yeah,
Let me
go on,
close
please.
it here. So the map also has two circles that you can see, the yellow and the red circle. The yellow circle represents where 95% of the keratoconus cases are located. And then the red circle, it represents the location of 99% of keratoconic eyes. And the white circle will be the circle that is calculated for our patient. So we see that this patient is located where 99% of the keratoconic eyes present the steepening. So we see that this eye, it really makes sense that it's a keratoconus case. We have some indices also that we've been using around, the symmetry indices, as you can see, evaluate a 3 millimeters ring and compares the superior with the inferior using 261 degree for the evaluation. And now we have a new index that is super interesting in detecting the cases when we have a central keratoconus. Early central keratoconus was not screened by the symmetry indices because everything was happening just in the center. So what is done now is that it correlates, or it compares the central 3 millimeters with the next 3 to 6 millimeters and gets an index from the difference between these. So it's the central symmetry index, and it's from the front and the posterior part of the cornea, super helpful in identifying central keratoconus. We have the composition of the elevation maps index and also all the thickness indices that we know from Belin Ambrosio and the thinnest point. And also we are using a symmetry index comparing similarly what we were doing for the anterior and posterior curvatures. We have the ability to click just here in the right or just press here left, and it will show us all the information in the keratoconus screening super fast. I will show you how to navigate on this a little bit later on. And we have a very nice way to evaluate our case as a mirror image. This is called enantiomorphism. So we here have the right compared to the left, in different maps, in the Gaussian anterior, in the Gaussian posterior, in the elevation anterior, and we can see that the images are mirror images in all of the cases in the point. So it's very helpful to identify cases where we have a keratoconus very evident in one eye and the other eye is not so clear. So it's very useful for these cases. Now, how we can use the OCT for the implantation of the corneal ring segment. It's super useful because it uses topographic and tomographic data for the identification and the analysis of the keratoconus, like Shady was saying. And for the surgical planning, it has a software that works amazing, and it allows you to play around and check all the possibilities of the correction. So it helps you to accurately identify the location of the cone, the centration, where are you going to center the rings, which axis are you going to implant the ring, and the depth that you can implant the ring in your case. And it's super helpful to follow up those patients. So you will check the position of the ring after the implantation with the section images, with the OCT images, and you are able to measure the effect and the stability using the differential maps and comparing the preoperative map with the postoperative map of all different maps available: tangential, anterior, posterior, thickness map, elevation maps, all the maps available. So here I will try to move to a team viewer to show you very quick this. Let me see if I can share here now a new screen. Mazen, can you see the Phoenix software open now in your screen?
Yes.
Okay. So this is how you were going to open a case. This is the right eye. This is the left eye. I will open the right eye. And here you can select to go straight away to the keratoconus screening software, where you will see all what we were talking about and all the indices. And then here you can select to go and decide to treat, for example, this patient with rings. It's very useful because you can, as I was saying, you can check the location where the ring is going to be implanted. We have the pupil center. We can use the centration of the ring using as reference the pupil, as reference the limbus, or the corneal vertex as reference. And we can decide to implant 1 or 2 rings, as you will see that they are appearing in the picture, and deciding which location or which point are we going to use as a reference for the centration of this ring. You can select different diameters. We know the rings come in different optical zone diameters. So it allows you to change and play on that and select different ring arc lengths. So we can decide to implant a ring with a shorter or longer arc length and see what we are planning to do and adjust our plan accordingly to the needs of each case. It also allows you to see what will be the possible axis of the implantation, and you can play between the notable points, for example, here, and the topographic axis, and decide where are you going to implant this ring. And if you are not happy with these two options, you can still change them here by using the dissecting line, that this line that is the middle of the ring, and it will give you the axis of incision to input in your femtosecond. To calculate the thickness, you can select at which thickness do you want to implant, and you can see what is the minimum thickness of the tunnel and decide if the thickness of the ring that you are planning to implant, it will be safe for this particular case, and depending on how thick is the cornea in the area of the tunnel. So it's super useful for this, and I will show you now in cases, particularly how this was done. So let me go to the presentation back again. So I will focus the presentation because all different shapes and types of keratoconus are calculated and done a little bit different. I get this question a lot. Where do you implant the rings? In which axis do you implant? And the answer always I gave is depends. So for Keratoconus Duck phenotype, this is using the classification of Alfonso. We always have doubt where to implant those rings. Are we going to use the manifest refraction axis? Are we going to use the axis from the topographic, the axis of the coma, or the cone location? There is always this doubt. So, and this is very useful to identify the location of the cone, as I was saying, and here with the notable points. And we see in this case that the topographic and coma are far away from each other. So we decide where are we going to implant this ring. But if we use here the notable points, we see that there is a point in the middle, and we cover very nicely almost all the area of the cone. Yes, an area that is less steep here than this area that is more steep, you will say, how do you correct this? You will be flattening more than what you want in this area, and perhaps you will be flattening less than what you expected in this area. So this is what you see, what I was talking to you, less flattening here and more flattening here that you want. So the solution for this was designed by Kerecs by Medifacos. Those are the progressive thickness intracorneal ring segments that were designed to achieve a more customized cornea remodeling. They are thinner in one end and they start becoming thicker until the other end. And you can see here in the section image where the ring is thicker and thinner in the opposite side. For example, for this case, I implanted a progressive thickness ring that it was thinner here and it started becoming thicker in this area. And particularly in this case, I also implanted a non-progressive thickness ring because I don't need a progressive flattening. I just need the same flattening all along this ring in the opposite way. And this is the differential map that I was mentioning to you. So you can see the preoperative of this particular case and the postoperative map and see the progressive flattening effect. We notice that here, this area, we achieve a greater flattening than in the area of closer to the superior temporal part. This is another case that I will share with you, the same story. The topographic and the comma axis are far away from each other, and the red on red is in a point in the middle in between. The notable points are in between. So as you can see, also less steepening of the cornea here and greater steepening of the cornea in this point. So we will need also to use a progressive thickness ring. You can see that the steepest point in this sagittal anterior map is in this location, but look at the Gaussian maps, what I was mentioning to you, and look at the thinnest point of the cornea. The notable points are passing just straight away to the area of the cone, and this is where we are centering these rings using the exact location of the cone, not what the anterior maps, sagittal or tangential are showing us. These are the differential maps. This picture is beautiful. It's one of the nicest cases that I have because the keratoconus was not very advanced. And you can see how nicely in the postoperative the cornea looks, how it regularized the cornea and looks almost like a non-keratoconic cornea. And we can see here in the image the progressive flattening effect being more in the area where the ring is thicker. It's important to understand when we are implanting rings that we know that the ring effect will be greater when the ring is thicker. It will be greater when the arc length of the ring is longer, and it will be greater also when we implant this ring in a smaller diameter. Also, if you implant this ring shallower, it will give you also a little bit of a greater effect. This is another case, the same story, very far away, the topographic and comma axis, and then the notable points in the middle. And this is what we get, very nice and customized flattening effect in the cornea that you can see here in the differential maps. This is the last case, a little bit more advanced keratoconus compared to the other ones, but always the same story. We have the difference between the topographic, the comma, and the red on red is always in the middle, in the exact location of the cone and covering all the area that we are intending to flatten and to correct, this bulging, this ectasia that we want to correct. Okay, this is the outcome of the same patient where you see more flattening in the area that we were intending to flatten more with a thicker ring segment. These are the results using this progressive thickness. This is under peer review, but we can compare the results with other publications by Alfonso and by Prisan that use the same rings, but in mixed phenotypes. He not only implanted in dog phenotypes, he also implanted in dog phenotypes. We can see that the results in vision and gain of lines of uncorrected and distance, corrected distance visual acuity was more in our study. Now I will share some images for you to see another applications that we have and how useful is the section images and the high definition of the section images. This is a patient where I implanted the rings after post-LASIK ectasia. So in red, you can see the flap, the stroma of the flap. In blue, you can see the epithelium. And in green, the definition is super high, that there in green, you can see the thin film layer of this patient. This is a case number 5. This, unfortunately, the patient is still growing his eyes, and we have here to explant the ring because it was extruding. So this is the scar that is left after the explantation of this ring segment. The superior ring segment in this patient still was there. We did not explant it. So this is what you see here in the other side of the section. And this is the last case.
Yeah, last case, yes, please, because time.
No problem. This is the last case. This is a case where rings were implanted after penetrating keratoplasty. And we see that the ring was implanted in the incision or between the recipient and the donor, but is not causing any dehiscence or any problem here in the flap in the graft junction.
Thank you very much.
Thanks.
Thank you very much.
Your time.
Now, there is a question to you, Juan. All these cases were accompanied by cross-linking, and when you did it? This is one of the audience.
Okay, yes. We treat all the the keratoconus patients that we implant rings, we treat them combined with cross-linking. It's not simultaneously, it's sequential cross-linking, and we do it after 6 months. This has an explanation, is because the changes, especially the topographic changes after implanting corneal ring segments, are seen even up to 6 months of the implantation of the rings. The visual acuity changes are just going, what the outcome is going to be, it will be shown around the 3 months postoperatively, but topographic changes is still happening during the 6 months postoperative. So this is the reason why I do the cross-linking. We have exceptions like kids, people younger than 18 years, especially these very young kids of 13 years old, 12 years old, that we do implant also intracorneal ring segments. For those, we don't wait 6 months. Then the risk of progression is much faster and higher. So in them, I do the cross-linking much earlier, around 3 months after the implantation of the rings.
There is another question. Does a steeper implantation of ring is more effective than shallower? I think I think the one who is asking means that deeper. So do you think that deeper implantation gives better result than the shallower implantation?
No. If you implant the ring shallower, the effect will be greater, but also it accompanies with the risk of extrusion. So we don't want to implant rings shallower. Normally, the recommendations by Medifacus is to implant the rings between 70 to 80% of the corneal thickness. I personally implanted the rings in 75%, but sometimes you can play along this, and you have to, with this progressive thickness, this is a question that Francesco asked me today. With this progressive thickness, for example, we have rings that start with 200 and become 300. So we need to consider also that the thicker the ring, we need to have also thicker corneas. But he was asking me, so what will you consider? If it's a ring that is 200, 300, are you going to consider an average of it, or 200 or 300? I was telling him, no, I will check the exact place of the thickness at the tunnel, and if the thickness of the tunnel is very low in the area where it's 200 and I am still within my safety parameters, I will calculate it for the 200, because you need to check is where is going to be the 200 and where is going to be the 300. So not an average, check the exact location where the cornea is thin, that you can do it very easy with using the software of the ring software of the MS-39.
Yes, thank you. And I would like to comment about this point, about the depth of implantation. We have to take into consideration that most patients with keratoconus, they have dry eye, they have rubbing eyes, so they are exposed to extrusion of the rings. So it should be as deep as possible, following the guidelines, and to avoid such complications. Great.
Can I add a comment here?
Yes, please, Shady.
So what I also am afraid, deep rings at the same time, as one said, sometimes they lose some of their effects. Sometimes they have intrusion, especially rings that are triangular in shape, because the patients rub their eyes a lot. So what I do at least is that, knowing that there are many studies, including a landmark study in IOVS that showed that the keratocyte population decreases dramatically down past 350. So if my calculation goes 430 or 400, I stop at 400. So 400 microns, because I really want to get some anterior stroma. I think 400 is deep enough, and it might be a sweet spot between too deep and too shallow. And as you said, I fully agree, these patients have dry eyes, they rub their eyes. So I don't want it too shallow, but also I'm afraid to put it too deep, even if it's 80%. So I try to, 400 will be a sweet spot between effect or not. I don't know if the rest of the panel would agree.
Yeah, fair enough, Shady. Thank you.
Yeah, with very thick corneas, as Shady was saying, if the calculation is saying that my 80% is 460, I will not implant the ring so deep. I will try to go at maximum. At the maximum, my goal is 420, but most of my rings are implanted around 390 microns.
Okay, great. So let's move to the next speaker. Jorge Aliò is going to talk about clinical application of MS-39 epithelial mapping. Please, Jorge.
Thank you very much. Let me share first my screen. Okay, I think it's ready. So thank you to CSO, and especially to Francesco Versace, that is a good friend of mine, for this kind invitation. And for me, it's a pleasure to be able to play with CSO devices. I think they have an outstanding technology and very interesting, and for sure has improved our practice as well as for the rest of the speakers, I'm sure. So in this talk, probably I will take or repeat some points that have already been pointed out, and likely Mazen on the next talk will also probably repeat some of the main concepts, but I think it's very important. And probably one of the main advances of the MS-39 and modern anterior segment OCT technology is that it is able to provide the epithelial imaging and the epithelial thickness maps. So one second, I'm gonna minimize this because I don't want to see my face all the time. Okay, better. So it has already been discussed in Reinstein in 2009, already introduced the relevance of mapping the corneal epithelial thickness for keratoconus screening, because it was already known the compensatory effect of the corneal epithelium that is able to mask mild underlying stromal surface irregularities by thinning over the hills and becoming thicker over valleys. So basically you can have a normal anterior surface, a normal anterior keratometry, but actually have an underlying problem that if you are not taking into account the epithelial thickness map, you might consider normal a cornea that actually is abnormal and pathological. And actually today, since I introduced for the last few years the corneal epithelial maps on our practice, I would say that probably today I couldn't do a refractive surgery without this, because it has become critical in my preparative assessment of refractive surgery candidates for laser mainly, of course. Because, and this is probably one of my best examples of this, no? If we don't see here, if we remove the epithelial map and we look at only the usual maps, the tangential and sagittal anterior, the corneal thickness and the posterior elevation, we could say that probably this is actually normal. It's true that I agree here the posterior elevation, it has some subtle changes, but I would say that here, if I only see this and the other eye is normal, I would do a LASIK here. But then I saw the epithelial map, and the epithelial map, it already see it was already demonstrating some focal thinning here in the inferior sector of the cornea. So this is normal, or is just an artifact, or is abnormal, and or an artifact of the epithelial thickness map. And actually, if we go to the left eye, we see that the left eye has a keratoconus, inferior symmetry, posterior elevation, and an obvious thinning of the epithelial map over the area of asymmetry. So actually, this was not a normal cornea, it was an abnormal cornea, and the most sensitive map was the epithelial thickness map. It's true that it's already known that the most sensitive maps on the corneal topography are the posterior elevation and the epithelial maps for keratoconus screening. But here I would say that, but my only concern was regarding the epithelial map when I saw it, and by the fact of looking at the contralateral eye, it was confirmed the diagnosis that this is not a normal cornea, it was actually an abnormal cornea. So the MS39 is a device that combines all the advantages of the series that a Placido topographer with a high resolution spectral domain anterior segment OCT, and then is able to provide a more accurate measurements of elevation, curvature, and refractive power of the whole cornea, including anterior and posterior cornea. And among pure anterior segment OCT devices, the MS39 provides the highest axial resolution, and only a few of them actually provide this technology, like combining topography and anterior segment OCT, because today we, as the phones, we like to have in our phone all possible options to pay, to phone, videos, etc. So I think the future is obviously to have the highest technology and the broader technology in a small device that is able to do so many things, and not have our room and our practice full of a lot of machines that only do one thing. And probably this is the way how it's pointing out the future, but only a few anterior segment OCT and topographer devices combined are available in the market, and the MS39 is the one that is actually today still providing the epithelial thickness map, because not all the devices as Antero is providing a epithelial map. So of course, this will change in the near future. And the MS39 is not only able to provide the latest generation topographer and an epithelial map, but also if you combine it with the Osiris, you can have, as Sadi already showed us, the very useful ocular wavefront aberrometry and other applications that probably are not the topic of this presentation. So in this presentation, I will focus in what is the relevance of imaging the epithelium, not only the maps that are, as well as we have seen, are very relevant for the keratoconus, but also the proper image itself, because in the last update of the MS39, then they included an anamorphic image of the corneal image. So basically what this is about. So if we have the corneal OCT image, and we do what the anamorphic image, what it does is a straightening, stretching of the whole image along the anterior corneal surface. So of course, this will deformate the image. So this is not the normal shape of the cornea. Okay, this is natural shape. This is an abnormal shape. But actually, it allows us to see detail in a few microns. So thanks to this anamorphic image, now we have a much higher resolution, and we can identify abnormalities of only a few 2-3 microns of dimensions. Like in this case of the epithelial basement membrane dystrophy, where we could see by the anamorphic image. Here we see the epithelium, the basement membrane, and the rest of the layers. But here we could see subclinical detachments of the epithelium that actually are not able to be seen either by slit lamp or by standard common anterior segment OCT imaging. So thanks to this new high resolution imaging of the epithelium, we can see things that before were absolutely invisible. And now we're going to see some clinical cases, where this epithelial imaging is especially relevant. We have already seen, and probably in the next presentation we will see again, the relevance of the epithelial imaging in keratoconus. As Dan Reinstein described in keratoconus, the epithelium thins at the cone and gets thicker surrounding the cone, giving what he described as the donut-shaped image, where it gets thin in the area of the cone and thicker around, giving this donut-shaped image and appearance. Here, of course, this is a quite advanced keratoconus case, but in earlier cases, as we have seen before at the beginning, or here in this case, we see where still we get this donut shape of the epithelial map, the thickness map, where it gets thinner in the area of the cone. Okay, you see where the thin area is just matching the area of the ectasia, with a surrounding thickening of the epithelium. And this is especially relevant because thanks to the epithelial mapping, we can now precisely diagnose those form frustre keratoconus or subclinical keratoconus that is especially relevant for refractive surgery, mainly LASIK. But even if but it's not a question of only the map, okay? We can all actually see it by the anamorphic image. We can see how this is not an invention. It's not an invention. Actually, we see that it's real, and we can see how in the area of the cone here we see the posterior elevation. This is the area of the ectasia, and how the epithelium is becoming thinner in the underlying the cone and thicker surrounding the cone, giving this donut-shaped image. But thanks to the epithelial mapping, we cannot only diagnose those apparently normal corneas that are actually pathological, but also discard those apparently pathological corneas that actually are normal, like in this case, okay, where we see a very suspicious inferior asymmetry, okay, but the posterior elevation is normal, anterior elevation is normal, the posterior surface of the cone is fine. It's true that the cone is a bit thin, but actually if we look at the epithelial thickness map, we see that this area of ectasia is because the epithelium is actually thick. So this is what we call the pseudoectasia. This is a patient that is not an abnormal cornea. It's true that if you ask me, I would do LASIK on this eye. Of course, I wouldn't do it because the cornea is thin anyway. So in this case, but if you ask me, would you a PRK? Of course, sure. This is not an abnormal cornea. This patient has only an inferior symmetry because of a epithelial thickening, probably because of a contact lens wear or whatever the reason. If it's a contact lens wear, then just wait, and probably as study shown us, this will become normal. And this is the contralateral eye, okay, where the same. So actually, we have symmetry among eyes with an inferior, very doubtful inferior symmetry, but where the posterior elevation is absolutely normal, the rest of the parameters are normal except the thinning of the cornea, but this pseudoectasia is caused by a thickening of the epithelium. Okay, so this is not a real ectasia, and you can go and continue with a refractive surgery, probably PRK, because of the overall thickness of the cornea. So this is just a thin cornea, but not a pathological cornea. But also this new way of identifying and diagnosing the cornea with epithelial images, we can now see things as we have never seen them before. This is a case of all of the cases are mine. This is a case of a smile where I had a mild epithelial ingrowth, but was getting worse. So I jacked those nests, and the epithelial ingrowth stopped. But the problem is that I had a residual induced astigmatism here. You see where in the area of the epithelial ingrowth, I'm having an induced astigmatism with the rest of the parameters being normal. And actually, thanks to this, we're gonna understand much better what is going on. So this is the standard OCT image provided by the MS-39, okay? Here we see the area of the epithelial ingrowth. This is the area of this is the sagittal plane of the smile. But if we do the anamorphic image, we're gonna much better understand what is going on. And what is going on is here, okay? So here we have the epithelial ingrowth. The problem is that it's a bulkulation, okay, that is pushing the stroma upwards and downwards, okay? And this is here, you will then now exactly understand why there is being an induced astigmatism, okay? Because there is a bulkulation that is pushing the stroma inducing astigmatism, and here you see how well is precisely seen the sagittal plane. And actually here you see again the compensatory effect of the epithelium, where it's getting thinner in the area that is being bulky, okay, with some lysis of the stroma, of the overlying stroma. So here what I did is just to evacuate this lytic material, okay, but being very careful because I knew that the overlying stroma was a bit lytic and probably affected by the epithelial ingrowth. Again, this is another case, very interesting case of typical posterior keratoconus with scars, where the patient was asking for some visual improvement, and I was assessing the option of doing a keratoplasty regarding despite the patient already knew that he had some degree of amblyopia. This is the anterior OCT image, okay, the standard one, and this is the anamorphic image. And here we see the posterior keratoconus has never seen before, and we can precisely understand what is going on. Here we see this is a posterior keratoconus, is very obvious, okay? Here you see how the posterior surface of the cornea is completely ectatic. The posterior surface is overall normal. Here, of course, there is some ectasia, but it's not as pronounced as is the posterior surface. And here we can perfectly understand the fact of the epithelial remodeling, okay? Where here in the area of the ectasia, we see the epithelium gets thinner. Here there is some valley where the epithelium gets thicker and then becomes normal. And here what was very helpful, this anamorphic image, is because when I only saw this, my idea was, can I do a DALC on this patient, or I have to do a penetrating keratoplasty? So basically, is the descending membrane involved or is not on this scar? Actually, it is. By the anamorphic image, I can precisely see details on a few microns to 3 microns, and is as good. Is basically, this is high resolution OCT, and I could precisely see how the scar is not only full thickness, but it's also affecting the endothelium and the descending membrane. And actually, then if I do a DALC in this case, it will be useless because the underlying tissue will still be opaque. So if you have to do something, it will have to be a PK in this case, because well, you can always do a DALC and do a little perforation here, but well, this is a bit more tricky. Very useful as well for late LASIK enhancements. We are quite fans, and actually I published this about what are the risks and the benefits of doing of lifting flaps for enhancements of flaps that are older than 10 years. Okay, something that we do as routine, although there is a risk that you should know of epithelial ingrowth. But this is the OCT image that you get when you do a topography. Okay, when you do a topography, you can always click OCT and it will give you an OCT image, but the resolution is not as good as the one you get when you do the scan with a proper OCT mode. Okay, where you see the resolution is much higher. But still here, you have to identify the thickness of the flap in order to determine if the enhancement you are going to do is safe or not regarding this residual stromal bed. It's not that easy to identify the thickness of the flap. But here, with the anamorphic image, you can precisely see, as Sadi already showed us, this black line that actually is the area of the surgical plane of the LASIK, of the flap. Okay, and then you can precisely identify how thick it is and what amount of tissue you have underlying the flap. And again, here you can still understand the epithelial remodeling about how the epithelium has got thicker in the area of ablation. Okay, that is the typical sign that has been already demonstrated after a myopic ablation, how the epithelium gets thicker in the center. Okay, and here you can not only see the map, but also you can see directly what is going on and understand what is happening. This is another case of a radial keratotomies, case that came with a loss of vision because of scars. So in this case, I was going to do a PTK, okay, to get rid of those scars and improve the vision. And then I did the OCT just to see how deep were those scars in order to planify the PTK, with the surprise that I see that these were actually like Salzman nodules like opacities, okay, because I could see that these scars were mainly within the epithelium and not affecting the underlying stroma. But with an anamorphic image, I could see much more precisely. Okay, I could see that these scars are exclusively located within the epithelium, and actually the underlying stroma is intact. So in this case, there is no need to do a PTK. I could do just a superficial keratectomy and that's it, because the underlying stroma is intact. So there is no need for laser. Just remove the epithelium and the scar will peel off with it. Okay, and this is the topography, the usual topography of an old radial keratotomy, where if you are not familiar with this, what you see is the similar anterior tangential anterior like in a all myopic LASIK with a central flattening and a quite significant spherical aberration here, but with the difference that the corneal thickness is normal, is not affected, because here you are not ablating any tissue. Here there is some decentration, okay, it's an old RK with the posterior. So basically in RK you have this donut shape in the anterior and the posterior surface, because in LASIK you only get it on the anterior surface, but never on the posterior surface, and unless you have a post-LASIK ectasia. Okay, but here you have this donut on the anterior and the posterior with no loss of tissue. Okay, but here now with the anamorphic image, you can not only see the map, the color map, but also understand how in the area of the keratotomy, the posterior cornea is becoming elevated, okay? And then you can directly see this posterior elevation in real. And this is the last case, okay? This is it was a quite surprise of this is a case that I had just a month before the COVID crisis. This is a case, this case presented to me because of a pterygium, and as you can see on the slide line picture, this is not a pterygium, okay? It's very suspicious of ocular surface squamous neoplasia, okay? And on the epithelial map, then you see how the epithelium is getting thicker in the area of the lesion, okay? But in these cases, before everybody used to do biopsies, okay? But Carol Karp is a person that has probably changed this field because of the description of the signs of the OSCCN with high resolution OCT. And these signs are thickened epithelium, hyperreflective epithelium, and abrupt transition from normal to abnormal epithelium. Okay, these three signs were described with high resolution OCT, but now thanks to the development of OCT, with commercial available OCTs, now the resolution is so good that it's able to provide and show these signs that actually, if you have this, you don't have to go even for a biopsy. You can make the diagnosis. Here you see how in the MERS39 OCT image, you see the three signs of thickened epithelium, hyperreflective epithelium with an abrupt transition zone. But actually, if you go to the anamorphic image, see how beautiful is the image, and the OCCN has never been seen like this before. You can perfectly see this abrupt transition zone from the abnormal dysplasic epithelium and the normal epithelium. How is this transition zone so perfectly seen and understood, where the epithelium, the carcinoma is thickened, the epithelium is thickened, obviously thickened, and hyperreflective. And thank you very much.
Thank you very much, Jorge, for this informative lecture. Actually, we learned a lot from you, and there is a specific question to you from one of the audience. Do you think that the epithelial mapping is more sensitive than the posterior elevation in detecting early keratoconus?
Well, one important thing to take into account in the epithelial mapping is that it could be easily artifacted. Okay, so patients with contact lens wear, dry eye, even not an accurate measurement. Probably the epithelial map today is more sensitive to be is more likely to be artifacted than the posterior elevation. So for sure today, the most useful signs to detect early disease are the posterior elevation map and the epithelial mapping. It's true that the available literature about the epithelial mapping is still not as broad as the one we have with the posterior cornea. My feeling now on my practice is that the epithelial map is actually as sensitive or even more sensitive than the posterior elevation. But the main problem is that you cannot exclusively rely on the epithelial map. Many times you can see a normal cornea with an abnormal epithelial map, and it's obvious that it's because artifacted. It could be a lot of noise. So either it's very useful, you should take it carefully. You should consider it carefully, because you might have abnormal images on normal corneas, okay, because of just ocular surface problems or abnormal or problems with the measurement, with the acquisition of the measurement. So my recommendation today is to see the overall case and rely on both the posterior elevation and the epithelial map.
Yeah, actually, I will answer this question as well in my presentation. Thank you, Jorge. Now, since we have good time, there are few questions from the audience to the panelists. So one of the questions, does the epithelium change by race or doesn't have any relevance? What do you think, Shady?
Well, there are a few studies now. I mean, there are a couple of new studies from China, almost similar to what Dan Reinstein and Carolina Rocha has already published. These are my own experiences. So I'm not aware of more than these 3 studies, one from the US and one from Europe and one from China. I don't know about the other panelists.
What do you think, Juan?
Well, I don't think it should be used alone, as Jorge was saying. And sometimes it can be artifacted very easy, because it's something that is changing continuously, and it can be influenced by many other factors like blepharitis or many other things happening in the ocular surface. Yeah.
Yeah, but do you think
it should never be used alone. What we have commonly see and what we have been reviewing with Jorge and Alal and Suri, all of those cases that are suspicious cases, we have been reviewed hundreds of those. We have seen that most of the patients with early keratoconus or keratoconus suspect cases have changes in the epithelium, and the posterior elevation are the earliest changes.
But Juan, this is not the question. The question was asking if the distribution of the epithelium, we know that the superior is thinner than the inferior, that the nasal is thinner than the temporal. I mean, the distribution, the thickness, everything. Is it? Do you know whether it is international is the same, or is it different based on ethnicities? Are you aware of any study or your own expertise?
I'm not aware of any study, but the study that we are doing with Jorge and Alal and Suri, we have different populations. We have Omani population, we have the population provided by Alal and Suri, and we have the Spanish population. And we have seen quite big similarities. However, this is the general impression. We have not studied this is not the focus of our study, but the general impression that I have, and I think I shared it with Jorge also, is that it's pretty similar in the different populations that we are evaluating right now.
Okay, there is another question, one last question before I start my presentation. What is the percentage of corneas that seem to be normal, but actually are masking an ectasia because of epithelium surface? So how often, let's say, how often do you see such cases of early keratoconus hidden by the epithelium?
The question is, shall I start myself? By the way, well, it is not uncommon, but it's not very common. I don't have an exact percentage, but maybe I would say in patients coming for LASIK, maybe it is like 3% of patients. It's just a very rough estimate. But I tell you one thing, I always look at the posterior curvature, and I noticed that all the panels do the same. If you look at it, I don't get swayed by an abnormal anterior. What was before diagnosed by Michael Bellin as a displaced anterior apex, remember, we know most of it is due to the epithelium, and he had the percentage, and I forgot what it is. You probably know more, Mazen, you'll tell us about it. But I noticed that if I look at the posterior curvature and it's fine, I'm relaxed. I look at the epithelium and it backs up my mind.
Yeah, I would agree with Sadi about maybe 5% of the cases. I think that the most important relevance of the epithelial is for those cases. For example, many people, when they have a doubtful topography, they are not sure if they should go and proceed with a refractive surgery or they shouldn't. Many people go to biomechanics, corneal biomechanics, Corvis, etc. No, we used to have the aura that now is quite outdated, no. But now the epithelial map has taken that place that for me had before the corneal biomechanics, that they still are useful, but for me it makes the difference for those cases where I'm not sure if I should proceed or not, because if I had some doubtful minimal asymmetry and the epithelium is normal or thick, then I'm safe. But if the epithelium is doubtful, then it's like red flag. So the epithelial map is mainly useful for those doubtful cases based on the other maps. Okay, so you should always do an overall the evaluation, because and also you should take into account that there is not available a precise and fixed values of the epithelial map that cutoffs abnormality and normality. We have published recently a few papers trying to point out these cutoffs of what epithelial thickness is normal or abnormal or where, but it's not easy. It's not actually easy, mainly because the measurement is quite vulnerable to many other factors, environmental factors. But always remember to do an overall evaluation.
Yeah, I agree with you. Thank you very much. So if you allow me to go to my presentation, and of course we will have sufficient time for discussion later because my presentation is not that long. Is it clear? my presentation is clear?
Yes, yes. Now.
Okay, great. I'm going to give you some tips, let's say the audience, some tips about the importance of the epithelial map in modern corneal imaging. Yes, now I'll go through the hotspot, the post-cross-linking changes, and I will present a case for discussion, open discussion with the panelists. Starting with the hotspot. Actually, you know that I am crazy in classifications and categorizations of things. So actually, I classify the hotspot into false and true. All right. From time to time, of course, we see such hotspots on the anterior curvature map, and we wonder whether they are signs of early keratoconus or maybe some artifacts, as the panelists had mentioned before, such as dry eye, eye rubbing, contact lens use. So first of all, we have to exclude, when we see such a hotspot, we have to exclude factors that may lead to artifacts or false findings, let's say, like using contact lenses, misalignment during taking the capture, large angle kappa, tear film disturbance, including excess tears and dry eye, corneal opacities and pathologies, previous corneal surgeries, bad or let's say inadequate exposure to the camera, and pregnancy. Now, if we exclude all of these things, then we can think about the ectatic corneal diseases. So we shouldn't think about ectatic corneal diseases and exclude the patient from, or the candidate from the refractive surgery before we exclude such sources of false findings. Now, what are the features of, in the epithelium, in the stroma, and on the posterior corneal surface that can help us in differentiating these entities from each other? Now, for the anterior surface, we have to study the elevation, we have to study the epithelium, we have to study the stromal elevation, and we have to study the posterior surface by using both the posterior elevation map and the posterior tangential map. And we will see why we should see the tangential map always. It is not adequate to depend on the posterior elevation map. But before we start, we have to know the properties of the epithelium that have been mentioned before by the colleagues, that the epithelium fills the gaps. So this is a case of corneal scar, and the epithelium fills the gap. So where valleys are there, the epithelium will thicken, and when there are mountains or hills, the epithelium will thin. As you see, this is an example, very good example of the epithelium remodeling of the anterior corneal surface. If you look at these two parts, you'll see how thick the epithelium is, covering the very irregularity under the surface. In addition, the epithelium thickens over the intracorneal rings. As you see, this is the same picture of the previous OCT. And in addition, the epithelium, because of this property, there are some clues that we can get benefit of in diagnosing early keratoconus. We know that the epithelium thins over the cone and thickens over the flat area, which is usually over the cone, such in this example. This is a case of post-myopia, because after myopic ablation, especially if the zone was very small, as Shady mentioned before, that the thickness, the epithelium will thicken, and this will cause loss of effect. In addition, we can see the same in the hyperopic treatment, where the ablation is peripheral and the epithelium fills the gutter or the ablation zone and causes loss of effect. Actually, there is an agreement between the epithelium and the stroma. The stroma says to the epithelium says to the stroma, if you steepen, I'm going to thin, and if you flatten, I am going to thick. So it is not related to the thickness of the cornea itself, but it is related to the curvature of the stroma. So this is an example. This is a stromal elevation, as you see on the left, and the epithelium thickness, because there is an elevation in the stroma, the epithelium thins, in order to hide this elevation, so that you will see on the anterior elevation that there is almost nothing. There is a scar. As you see, in the scar, usually we find shrinkage in the cornea, and you will find that the cornea is flat. So because the stroma is flat, the epithelium is going to thicken. So as you see, this is, on the left side, you will find there is like a flattening in the stroma. In the middle, you will find a thickened epithelium, very thick epithelium, in order to hide. And as you see, the anterior elevation is very smooth. So what are the features of the ectatic corneal diseases based on these changes in the epithelium, anterior stroma, and the posterior elevation? We all know that any ectatic corneal disease will start from the posterior surface. There will be an irregularity, or will be outbulging of the posterior elevation or posterior surface, let's say posterior surface. After that, when the keratoconus progresses, then this will transfer to the anterior stroma, and the stroma will bulge out as well. And this can be shown on the elevation, the anterior elevation map. The anterior, the stromal elevation. The stromal elevation will be shown on that one. And whenever it increases, then the epithelium will be affected, of course. But as I said, it will thin in order to maintain a very regular anterior corneal surface. Now, whenever this increases more than the capability of the epithelium to compensate for that, then there will be irregularity on the anterior corneal surface. So whenever we see anterior corneal surface irregularity, it means that the irregularity in the anterior stroma is severe enough to go beyond the capacity of the epithelium to compensate for it. So what are the epithelial changes in the ectatic corneal diseases? We have focal thinning, we have inferior superior asymmetry, radial thinning, and generalized thinnings. So these are the patterns in the epithelium that can characterize the ectatic corneal diseases. This is focal thinning, as you see here, and this is inferior superior thinning or asymmetry in the epithelium. This is another type of inferior superior asymmetry, and this is the radial thinning in the epithelium. And this is the generalized thinning. There are stromal changes in the ectatic corneal diseases characterized by the inferior superior asymmetry, as in this case. So whenever we see this, of course, it is not, we cannot depend on only one sign. We have to correlate with other signs, but this is one of them. Now, what about the posterior surface changes? As I mentioned before, we have to study both the elevation and the tangential map. In the posterior elevation, usually in ectatic corneal diseases, we see such patterns like bulging or island protrusion, outbulging. And on the tangential map as well, we can see such hotspot. But why we have to study the tangential posterior? Because in many cases, the tangential posterior starts showing changes or asymmetry before the posterior elevation map does. As in this case, as you see in the bottom on the left, the tangential posterior, and in the middle, the posterior elevation. So as Dr. Shady mentioned before, that this pattern in the posterior elevation can be seen when large angle alpha or large angle kappa or misalignment during taking the capture. So it is not characteristic to keratoconus. So it's better. So we have to study the tangential posterior. So to summarize, the changes in the ectatic corneal disease starts from the posterior surface and goes to the anterior surface. So whenever we find epithelium changes and posterior surface changes, then we can say it is ectasia. This is a case of keratoconus, as you see here. This is the sagittal anterior. There is a hot spot, and there is inferior superior asymmetry on the epithelial thickness map. And there is as well an island on the posterior elevation. This is another one of keratoconus. We have the hot spot, and there is the radial changes in the thickness, and there is the island in the posterior elevation. Now we come to the dry eye disease and contact lens warpage, because they are together, let's say they cause the same problem. Actually, there are two patterns in the epithelium that we see, the thickening or the irregularity, but we never see thinning in the epithelium because of dry eye or because of contact lens. And we can add the two factors that Dr. Shady mentioned before, which are the pattern of sleep and the rubbing of the eye, of course. So there will be thickening or irregularity. But as you see, the stroma will be not affected and the posterior surface will not be affected as well. This is a case of dry eye. We have inferior hotspot, as you see, but it is false hotspot because, as you see here, there is thickening in the epithelium corresponding to this hotspot because of the dry eye, and the posterior elevation shows nothing. And even the stroma elevation doesn't show any inferior superior asymmetry. This is another example of dry eye. There is irregularity on the sagittal curvature map. There is irregularity on the thickness map. There is nothing specific on the posterior elevation. This pattern may be seen in large angle kappa as well. And there is no inferior superior asymmetry in the stromal elevation. This is another example of the dry eye. We have very thick epithelium. We have irregularity on the cornea, very thick epithelium, nothing on the posterior elevation, and nothing on the stromal elevation. This is a case of contact lens warpage. As you see, there is a hotspot on the sagittal curvature map, and there is a thickening of the epithelium rather than thinning, and there is nothing specific. As we see, there is this pattern, which may be because of angle kappa, and there is no inferior superior asymmetry on the stromal elevation. So to summarize regarding this part of the presentation, that whenever we see an irregularity, we have to study the epithelium and we have to study the posterior elevation. Whenever we find the changes on both, then yes, we can say ectatic corneal diseases. Otherwise, it may be something else like dry eye or contact lens warpage or rubbing of the eyes. Now we come to the other part, which is post-cross-linking changes. I want to present this case. This is a case of cross-linking done, as you see on the left side of the, on the right side, and on the left side is after, right side is before, 6 months apart. This is using the anterior elevation. And the map in the bottom is the difference map. As you see, the difference map doesn't show much changes. But if we look at the tangential anterior as well, before and after, and the difference map, we can see there are few changes, but it is within fractions of the diopter, 0.6, 0.44. So nothing significant. But if we study the epithelial map, as you see, before the epithelial map and after the epithelial map, look how much regular the epithelial map, and it is getting thicker after the cross-linking because of flattening of the stroma. Because as we said, when the stroma flattens, the epithelium thickens. So if you look at the map in the bottom, you will see that there is thickening in the epithelium. So one of the clues that can reassure us that the cross-linking has worked is epithelial thickening, because sometimes we cannot see this effect by using the elevation map or the tangential map, as you saw in the previous two slides. And the other map that's perfect to show the effect of the cross-linking effect is the refractive equivalent power. This is before and this is after, and you can see at the bottom, the difference map, very good or very significant change, -5, almost -5 diopters of the refractive equivalent power of effect of cross-linking, flattening effect. So in this particular, on this part of the presentation, I would say that if we want to follow the patient with cross-linking to monitor the effect, to monitor failure of the effect, then we have to study these two maps, the epithelial map and the refractive equivalent map, rather than the tangential, and the elevation. The last part is I'm going to present this case and open the discussion, and I will ask the panelists what to do for this case. I didn't do anything for this case. I'm just asking because I want to learn from you. Now, this patient had LASIK, and she came back. She is not happy because of high order aberrations, actually, not because of residual refractive error. And this is the 6 or the hexa maps. As we see that there is very thick epithelium. It is about almost 100 or maybe 100 and more. The high order aberrations are very high, 1 point something, on account of spherical aberration, 0.54, and the residual, which is mainly the trefoil, which is 0.83. The comma is high as well, 0.4. So the patient is suffering from the high order aberrations. If we get back to this map, we can see that the epithelium thickness, the corneal thickness is around 470 plus, 470 to 480. Now we go to the OCT. If we look at the OCT, we can see that the flap thickness is 100 something, 104. So most of the flap is epithelium, as we see here. So this is the map again. The epithelial map is very thick, but it seems that most of the flap is epithelium. And the patient is suffering from high order aberrations. So what to do? I will start with Dr. Shady. What do you think, Dr. Shady? What to do?
Mazen, can you show me again the OCT photo?
Yeah, sure.
Mazen, I think the first thing you need to do is to check the identification of the epithelium, because this map, it doesn't appear to be taken from a 10 millimeters topography or from a high definition section. It perhaps is from a 16 millimeters, and the quality is not so good. So it's very difficult to see it in this map. Perhaps the Phoenix software identify wrongly the epithelium. This is my first impression before going and checking everything else.
Exactly. That's why I asked about the OCT, just to make sure to understand if we can see what from the flap and the epithelium. It's hard to tell. For me, I can see as if this is the Bowman's up, and I feel that the epithelium should be thinner than what it is. So I see that the Bowman's membrane is up. Exactly. So the epithelium should not be 100. Should be maybe less than that. It should be maybe 60, 50.
60.
Yeah.
Yeah.
It should be 60.
I'm not sure if that epithelial map is artifacted, because I agree that it can be. It's true that as Juan said, the OCT image is not very high resolution, but this epithelial thickness map, he looks, I think, I'm not sure if it's quite artifacted, because it can't be. No, it would be, there would be any flap. It would be just like a hyperplastic epithelium. So it might be an artifact there.
Hello?
Yeah.
Now the problem is, if it was the real true epithelium, what would we do if after identifying after checking the editing option of the epithelium, if it's really truly thick, is the question that you have, Mazen, right?
Yeah, exactly.
Yeah, here the strange thing is that despite this is a myopic ablation, on the aberration map you're having a quite significant negative spherical aberration. This is quite weird considering that this is a myopic ablation with central flattening. So I'm not sure. And actually, if you see at the stromal elevation map, I'm not sure if I don't know if there could be any haze that is making this corneal topography artifacted. I might do an Osiris to see what is going on regarding the ocular wavefront.
Mazen, the spherical aberration, okay, so how much is it again? Let me see.
Spherical aberration is 0.54. It is plus.
It's plus. Yeah, it's positive spherical aberration. So
Positive,
it goes, but my hunch, honestly, is that the epithelium is thinner, And in theory, if again, I would agree with Jorge, I always like to do like a Paramus or a Xyrus to get the whole picture. I will repeat again the high definition OCT and maybe repeat the measurements. And if the epithelium is thinner and then the aberrations are warranted, and I know that this is mainly from it, based on the ocular and the corneal, I would take a decision whether I want to treat with ocular or corneal wavefront. Again, I mean, I would look at both, look at pupil size, but again, make sure first that the epithelium, I can get a real good epithelial thickness.
Okay, let's assume that this is the worst scenario. It is, most of it is epithelium. What are you going to do? Are you going to ablate?
But again, there's something weird. I mean, if it's the epithelium, how could a flap, I mean, why would be most of it the flap? There's something, so you mean that the flap is not actually 100, maybe 150, because I mean, it cannot be that the epithelium becomes the flap. There's some stroma there. You know what I mean? There's definitely an additional.
Yeah. Now I asked, sorry for interruption. I asked the surgeon who did the surgery. He mentioned that he used the 90 micron flap, 90 micron. So the flap was 90. 90.
Okay. So maybe it was even actually, maybe it was even less, like as an SBK or something, right?
Yeah, exactly. SBK, yes.
Yeah. I mean, the most important thing is really knowing that how much is the epithelium. That's the most important thing. And if we have this, there are two ways to deal with it. I actually, there's something very important here, and we have to mention it, is that the central epithelium is pretty good. If you're doing transepithelial PRK, the central epithelium actually is commensurate between what you measure with the MS-39 and what lasers like the Schwind MRS or other lasers use, because it's actually vertical, and at the same time, the MS-39 measures perpendicular to the epithelium, normal to the epithelium, while the laser measures as coming vertically. But peripherally, it's going to be different, because again, what is shown, and it's the same thing when Dan Reinstein showed with the Artemis, the peripheral will be more if you take the reference point as a point which is higher and almost parallel to it. It will be 65 versus still it will be 50 here again. So what I do, I convert the peripheral epithelium, because here it's very tricky and I want to make sure. But as Juan mentioned, is weird because it's going all the way. But centrally, you're pretty sure. Peripherally is actually what's different. And in theory, I would proceed still with the transepithelial approach if I can. What I do, I mean, that's me, and I would not. I would say everybody might have a different technique, but I would actually. I have a certain formula that will translate that thickness into the laser, because it's going to be a different reference point. That's going to be even much higher. And then I will check it actually by OCT and double check through several HD quadrants that actually my calculations are along to what I see. And I would still proceed with it. You could always remove the epithelium again, but that's a completely different game here. And I don't know how the epithelium is going to heal.
Yeah. Okay, thank you very much. Thank you very much. So let's, yeah, hello, can you hear me?
Yeah, Jorge, Juan, any ideas here?
Yes.
I think what I would do is I would try first, as we discussed, to see if this is the true image of the epithelium. Later on, treat aggressively the ocular surface, and then decide what will be the next step. But the most conservative step will be just first removing the epithelium to see exactly what's going on. Perhaps that will be the issue. Perhaps the epithelium will grow back again, and then you can try a different approach, either a trans-PRK, transepithelial approach, or a normal PRK approach. But as Shady said, he published with Samuel recently the measurement and the ablation of the epithelium. Since the laser is shooting from the same place, it will be doing less in the area because it's not ablating perpendicular to the epithelium. So you must be careful of what you input if you have the Schwinn-Amaris, for example, in the epithelial ablation, because you might be hypoablating epithelium in the periphery if you don't adjust this based on Shady's publication.
Yes,
yeah.
I think first here you need to check the ocular surface to make sure that the scan is not artifacted, and once you are sure, then probably the treatment looked quite decentered. So probably the decentration is playing a role on the quality of image and quality of vision of the patient. So I think here is a case where a customized treatment, it would be likely necessary. So here, then you need, I think, the ocular wavefront, and according to that, planify a customized treatment. But first is to rule out this abnormal epithelial map. I don't think it is actually accurate, and probably is an artifact, whatever the reason, because you just can't have more than 100 epithelium and then an underlying flap. Something should be there, something strange.
But the coma is not super high. I think it's mainly from this epithelium what is inducing this coma. So I don't suspect that this was maybe at the center treatment. What the stromal map will let us think that it might be looking like as a the center treatment. I don't think it's the case. I think it's most of the coma is coming from this very thick epithelium.
Yeah, I agree. Again, Mazen, the Bowman's layer, look at the Bowman's layer, it looks pretty shallow. So
yeah, I agree with you. Yes, exactly. Okay, great. Thank you very much. Now I have actually 3 questions to Francisco. Is Francisco with us?
Sure, I'm here.
Okay, great. Now the first question, let's say in the coming software of the CSO, Bell&Ambrosio display is going to be implemented there?
We are going to implement some part of the Bell&Ambrosio. What is published, it might be implemented. For sure, we already implemented the Renato Ambrosio chart, the one showing the progression of the thickness. And if you look at the presentation of Juan, you already seen it. And we also some indexes based on this. So we have an index based on the thickness progression. And we already implemented also for the next version of Phoenix that is going to be released in a few days, the Belling grading, the ABCD grading. So,
exactly. That's what I wanted to ask you about, the ABCD Bell staging, keratoconus staging. Great.
It's one of the way of staging of the keratoconus that we implemented into the version 4 of the software.
Yeah, and the third question is, let's say, we know that there are formulas of the IOL calculation in the machine, the software, but what about the axial length measurement in the next generation?
Yeah, the axial length at the moment, I'm allowed to speak just of the current device, so I'm not allowed to speak about what is going to be the future. But at the moment, the axial length is to be tapped in from an external source, so you make the measurement with some kind of device able to measure the AL, and then we have our built-in ray tracing that is able to perform the calculation of the power of the IOL and the cylinder of the IOL, taking into account the shape of the cornea and the axial length that you inserted.
Okay, thank you very much. Since we have only 3 minutes, if the panelists would like to highlight some points before we conclude.
Well, regarding what you were asking before about if there is any difference on the epithelial map among different ethnicities, the real thing is that in our practice, I think that the evidence is not that wide enough in order to establish a conclusion on that. Although it's true that in our practice it's quite international, and I've not seen relevant differences among different races. So probably all that we have discussed on these talks probably applies to everybody. No, I think the differences are more inter-individual, about the different persons within the same race could show quite important differences, but not because of the race, just because of the different people and different persons.
Okay, great.
Thank you very much. There is a question from the audience that says, my clinic has an MS39 and a pentacam. Is there any need to use both of them during refractive screening, or can we just rely on the MS39? In other words, is there anything the Pentacam does that the MS-39 cannot? I want to have first the feedback of you guys, and then later on I'll tell you my experience.
Actually, I avoided this question to avoid any commercial or financial interest. So let me ask you the question, Juan. What do you think?
Well, I have no financial interest, but either in Oculus or CSO. But even since before having the MS-39, we stopped using the Pentacam. Before we used to do Pentacam and Scout for every single patient. Since we got the Sirius and the Keratoconus screening software was developed, we stopped using Pentacam and Scout for all of the patients. We were just using the Sirius. Now with the capabilities of the MS-39, I personally don't see any need of the Pentacam. I don't know if you guys prefer to answer privately or something, but I would love to know your opinion also.
Let me try to answer to this question, even if I'm not the right person to answer to this question. The only benefit of using a sham-through camera instead of an OCT is that the sham-through camera gives you also a good idea of the opacity of the media. So, which is also the weakness of the sham-through camera, because also the processing is affected to this hyper-reflecting stuff. So if you want to see the opacity of the cornea, you see it much better on the sham-through camera respect to the OCT. But this is also a weakness because due to this fact, maybe the sham-through camera are not able to measure correctly the thickness when you have AIDS or when you have after a cross-linking procedure. Do you agree, guys?
Yeah, I fully agree, Francesco. Actually, I do 3 different topographies and tomographies in my clinic, and I'll tell you one thing. I learned it from many people like Rob Osher and then Jerry Tan, and I know that even though a machine might be great, there are different variability. Like we just saw already, Mazen showing us an interesting variability, and sometimes it's a variability of the operator, sometimes the machine itself. I mean, we all know that the #1 limiting step in the IR calculation is SIMK, right? And then if you do a SIMK, if you have 3 machines and you do the SIMK, if the 3 of them have almost along the same limits, then you know you're doing fine, especially if you're planning any type of premium IOL. But if one is an outlier, that might be due to dryness, that might be due to other things, and you might want to repeat, or if all of them don't agree at all. So I like to do that on different machines. That's #1. #2, again, without going into very commercial here, but with the Pentacam, I think the more important thing is, are we talking about Corvus, the biomechanics, or not? Because I think always the biomechanics are nice to include if you have it. But if you're talking purely, if I have to decide on one machine, if you tell me use one machine, of course, I would love to have one machine that has an OCT, and I can look at the epithelium before and after. I can look at a rigid posterior curvature before and after. I can plan my aberrations. So if it was one machine, that would be an OCT machine. That's for sure.
Yeah, personally, I agree with you, Dr. Shady. I agree with all of you that if the OCT is there, no need for other types. Personally, I prefer the OCT, the MS-39 over the Pentacam. Yes. Okay.
Also remember the Placido disc complementing the results for the anterior curvature. It's very important if you're going to do corneal wavefront guided treatment than just shampoo of anterior curvatures by its own.
But I think again that having, if having the luxury, if you have very serious refractive practice and having more than one machine, I think it has, I mean, there's always, every machine have, even in their analytical, there's one machine that I use with Placido and Shapik that has an excellent posterior curvature float. And actually, I really love the way they do their posterior curvature, even though the problem is that it's shine float. So at least when the patient does not have much haze and clear, I like to do it, and like to look also at the MS-39, they complement each other. But again, I think it depends of how serious of a refractive surgeon you are. If you're a refractive surgeon doing regular LASIK is something, but if you're doing more complicated cases, I think it's nice to have, you know, at least 2 different platforms for me. But again, if I have to choose one, I'd like to have an OCT one. A Placido and OCT, like Juan was saying.
Okay, thank you very much. I'd like to conclude this session. It was very informative. I learned a lot from you all. I'd like to thank CSO for arranging this and inviting us. Now I'll give the word to Francisco.
Thank you to all you guys for being so nice and to attend this meeting, even if it was late in the evening. I would like to thank you for your time, and thank you also all the attendees that were many for being with us. And so see you next time, hopefully in person.
Thank you, Francesco. Thank you for everybody. Jorge, Juan, and
thank you.
Mazen. Great moderating. Thank you so much.
Thank you very much. Goodbye, everybody.
Bye.
Thanks to the audience as well. Goodbye.
Bye. See you guys. Have a good night.
Bye-bye.